We also have a project on the Thailand-Burmese, I guess, border, because there is a big conflict going on between in the Burmese government, between the Burmese government and the Burmese people living on the eastern side of the country, where they're forced to flee from Burma and they have nowhere to go but to Thailand. And so they live in refugee camps. Now, the complicating issue about that is that Thailand doesn't want these refugees, and so has not signed the United Nations High Commission for Refugee paper, or the document that really says that these people are refugees under the United Nations and come with a certain human rights, and understood that they'll be protected under these sanctions. So now they exist in this purgatory between two countries where they're just stuck there. They've been there for 22 years. And that big problem and a big conflict area, it hasn't really been advertised until very recently. Now, the last time I spoke in the first offering of the course, that wasn't a big thing that was being talked about, at least not on any sort of foreign policy. But now that the Burmese government is starting to make more public attempts at changing their policies, they're able to get more media attention because they're reforming some things to improve human rights. But we thought, well, you have now these individuals that are living in pretty bad conditions on the Burmese-Thai border, but they have no skills. And they're just sitting there consuming resources, and they're not wanted by anybody, and they're not really citizens of any country. And so we thought, well, could this be an opportunity to help using some technology to make these people maybe more skilled or more accepted in the country that doesn't want them, or in the country that has just kicked them out. So we came up with a project called the Thai-Burma Stove Project, and we developed a high-efficiency stove. And so the stove is, maybe I'll talk a little bit about it in this setting, is very simple design. It's a rocket stove, and it uses any solid-state fuel, but it dramatically reduces the environmental impact that these communities can have, because these fuels use significantly, or these stoves, sorry, I mean, use significantly less fuel. And also, by creating vocational training programs, individuals can actually have a skill set that they can give back. So looking at Thai villages around them, they're seen as a burden to the environment, a burden to their country, and they're getting handouts. They're just sitting there like hands and mouths, just being fed. And so we thought, well, we're not going to be able to change global policy. We're not going to be able to change the Burmese or the Thai government's, I guess, policies or laws on that. But we thought maybe we could train them to have some skill sets and then buy the materials from Thai villages, hence creating an economy of the Burmese people actually benefiting the Thai people, and it's starting to help create more dialogue and more communication and improving this idea of global citizenry and global citizenship between those two groups. And so I think this is probably one of our more political sort of projects, but it has managed to have or is starting to have an impact in this political realm that we tend to stay out of. But just through a technological introduction, we've been able to create some dialogue. These are some people that are working on the stove project right now in one of the Burmese refugee camps. So now, I talked a little bit about myself and a group doing this. And the group that we founded was called IC Change, or Innovative Canadians for Change. And I think our mandate is pretty broad, but we try to improve the quality of life and security of vulnerable populations. But how do you go about doing that? So there's technological groups that do a lot of that, and there's people that do human rights work. But we thought, well, the biggest thing that we need to do is to come up with a model where we can come up with a technology. We can start here. And so we have an approach to how we innovate new ideas. We come up with a model or a technology for sustainable development. We collaborate with local partners, and we ensure that the testing through implementation is done. We build capacity, make sure that the monitoring and evaluation phases are done, and this goes back and forth where we monitor and evaluate something and we realize the filters can't be made this way or this intervention can't be made, and it goes back and forth between implementation and monitoring and evaluation. And then once we come up with a sustainable model, we disseminate this globally and we allow it to be open source, and we ensure that individuals who are interested in this can have access to how we did it, how our blueprint of how we went about doing it is laid out. And so far, it's managed to help some groups in developing ceramic water filters and also new ideas, and to have maybe the courage to venture in this world, which is both challenging but also very exciting. Now, I wanted to leave this project for last because it's probably the most it hits home on a lot of these points that I talked about, both from a technological point of view, but also from a human rights and a global citizenship point of view. And so in thinking about our approach to innovation, we started to really distill all our ideas into one or two, actually we have 2 or 3 new projects now that have that philosophy built into them. And we came up with a project called the Kibera Medical Record Initiative. So this is a map of Kibera. Now Kibera, and I initially had some photos, but I took it out for the sake of time, but maybe when I send you the PowerPoint, I'll have some more photos. Kibera is a slum in Nairobi, which is the capital of Kenya, and it has a large population, probably, I mean, estimates range, but 800,000 to 1.2 million people living in extremely destitute situation, but are living very close to each other in a geographically packed circumstance, where some places they have per square kilometer there's 25,000 people. Now Canada has, I think, less than 3 people per square kilometer, and these people have 25,000. So that's pretty much somebody adjacent to you at all times, and any disease that happens gets transmitted very readily to individuals, but also their quality of life is very low, and so they don't have means to access healthcare. Despite all that, there is numerous clinics that have sprouted up. So this is a picture of all the clinics that are currently working in Kibera. There is probably over 95 clinics working there. Now, this seems like a great idea, but really it's again a concept of just vertical transmission. So we want to create a clinic, and so we're going to go there and build a health facility, and that should ameliorate people's lives. But it's a bit more complicated than that, because these clinics now have become a source of revenue for a lot of individuals, and so they operate in isolation, and they don't communicate with one another, and so all these clinics have their own health systems and their own patient information, which they don't share. And we thought, well, there's a problem with that. How can we use a technological innovation to help not build more infrastructure, nor come up with something new, but really to just link up these clinics together? And so we thought a medical record system, and even more gutsy than that, an electronic medical record system would be a crucial and necessary part of these clinics in particular, and in this slum. So I think a lot of people are hesitant about the idea of introducing something like an electronic medical record in a slum, because they're not seen as technologically savvy, and the whole concept of appropriate technologies is limiting. So if an individual is poor, they should have an appropriate technology for them, so something like maybe more basic technology, something simpler. Maybe paper records would be fine. They don't need something as fancy as electronic medical records, because I mean, even Ontario doesn't really have electronic medical records on a provincial scale. And so, but we thought, well, like I mentioned before, the penetrance of cell phones in an area like Kibera is over 100%. So they have incredible IT networks and also access to information technologies beyond anything we understand. And also the population density helps remarkably in doing that. So we thought that we would pick a number of clinics and introduce a system called Openmrs. So Openmrs is an open medical record system, which is open source, and we are customizing it to introduce to initially these clinics that you see highlighted in blue. These clinics are the pilot clinics, and the goal of that is to help network clinics together. That way, if an individual comes to one clinic and decides that they need to go to another clinic, the physician doesn't have to start from scratch. Now, from a physician point of view, when you see somebody, you can take the history, but you need their past medical history to help in coming up with a diagnosis. Because if somebody comes to you in that part of the world and says, I have a headache and fever, you're going to say that's malaria because you don't have good tests to say anything otherwise. So you're going to treat them for malaria. And now, meanwhile, if you knew their story, it turns out they've had this headache and fevers for months and they've been losing weight, and it turns out that really they have a cancer in their head, and you know, they haven't been seeking the right appropriate management, and every time they go to a different clinic they get anti-malarials and they haven't really done anything for their cancer. So beyond that though, from an economic point of view and in addressing people who say that it's not an appropriate technology, we thought that this creates a system of referrals. So different clinics specialize in different things. And so if I have a clinic that has a lab and an individual has a clinic that has, let's say, an X-ray machine, now having a shared medical record system means that the labs that I take at my clinic are able to populate a database that the person at the X-ray place can access for their patient. And they can upload their X-rays onto that system. And that means I don't need to have a lab, and that person doesn't need to have, or I mean, I don't need to have an X-ray machine, and that person doesn't need to have a lab, which reduces the duplication and reduces the cumbersome bureaucracy of these healthcare systems. And we're able to network these clinics more effectively. So by creating these networks at the same time, we can start to have a lot of information coming in from these individual clinics because they see more and more and more people. Particular things like HIV is very stigmatized in a lot of the developing world and even here in North America. And so people seek care in faraway places for their HIV. They don't want to be known in their community as HIV positive. So they walk for hours to a clinic on the opposite side of the slum, and that's where they seek their AIDS intervention. But their primary health care, where they get sick with belly pains and such, they go to the clinics near their houses. Now that creates a problem for the doctor who sees only the patient who has belly pain, or the patient who only sees the guys who have HIV, because there is a significant portion of the history that's missing. Now that all that information is coming in, there is a way of understanding that information and populating what's called a geographic information system. So let's say at your clinic, 100 people are seen every day, and 10 of those people are actually presenting with diarrhea, and you diagnose cholera in 10 of these people. Now this might be a normal day for a slum like Kibera, but in particular, if those 10 people all came from one area, in one particular part of the slum, now that's a problem of an outbreak. And so where these 10 people are all using the same water source and they're all getting cholera, that could potentially be a way to pinpoint an intervention, go out and fight that, let's say, broken well that has now cholera in it, and we can actually intervene on a public health level. So this medical record system has been able to create more information and populate geographic information systems. So you can track things like cholera, like HIV incidence and the resistance patterns across different people in the slum, outbreaks like TB that are transmitted through aerosolization or through, I guess, just respiration, and can even help tailor vaccination campaigns where you know that there's 100 kids in that particular area that need vaccines, and so that can be targeted. That's a way of really utilizing technologies and building complex systems and thinking really in terms of systems and processes that doesn't require building infrastructure, but it streamlines already available infrastructure to create better outcomes. And I think that's our role really as global citizens. Now, one of the more abstract and complicated parts of this project is the insurance part of it. Now, insurance tends to be a risk and premium ratio, where an individual who is seen as high risk gets charged high premiums. So young males are charged higher premiums for car insurance than young females. And that's because they're known to have more accidents and they are more reckless in a particular age group, and so they're more risky and hence need to pay more insurance. Now, people in a slum like Kibera tend to be seen as extremely risky, and so their premiums are extremely high, and nobody wants to insure them. So what we've been able to do, and in the model that we've built, is that as more information comes in through this electronic medical record, an individual has a way to show that they've been compliant with their medications, that they've gone and sought medical care, that their risks are decreasing if that's the way they're going. And so you might start out with a high-risk individual paying high premiums, and over time showing that they're compliant with their antiretrovirals and all those other things, and their health insurance will come down. And so what that leads to is a paradigm shift, really, and flipping the whole system upside down, where instead of people needing to pay more to get healthier, now by getting healthier, they're making more money or they're saving more money. And so really the way we've also done that is through ideas in using M-Pesa, which is a system available through one of the big telecommunications company where you can transfer money over your phone. Now, all these people have cell phones and they can pay their health insurance over their cell phone, and it can just be a micro insurance payment of a very small amount of money paid daily over their cell phones that can insure them and give them access to continuous and quality medical care. So the goal really is to have a system that is operating in harmony and is both connecting clinics together to improve diagnosis of patients, but also helps create a referral base that can then save people money. But also, if I have a lab, people are being referred to me, I'm making money, and I can refer people who have x-rays and they're making money. And so it's a business and a financially beneficial program. At the same time, it creates a way of tracking diseases and epidemiology and incentivizes insurance through decreasing risk premiums. Now, how does that relate really to global citizenship? I think this project in particular, because now these individuals who are living in slums are seen as illegal settlers, and they are not being I guess, accepted by the government as citizens. They're being seen as these people who are fringe, and they don't really exist. But now what we're doing is we're using the electronic medical records as a way to create an identity for these people, and hence through that identity, which is a very, very crucial thing for human rights, we can improve their quality of life as well as security. Now, if somebody goes missing right now, nobody would know what happened to them. But if they're registered in a medical record database and they exist through an identification system, that can also be a form of security for them. The important thing is that identity and even a technological presence is more and more being seen as a human right. Access to IT technologies are being pushed to be a form of human right, because people, if they have, like I mentioned at the beginning of the talk, that if they have access to information technologies and information in general through any sort of route, they're empowered and they're able to find the opportunities and stay connected to create livelihoods for themselves. And this also helps us leverage governments and legal systems to improve the quality of life and security of these vulnerable populations. Thank you.
So this really brings me full circle in the following somewhat amusing way. In 1988, following the big earthquake in Armenia, I put together this worldwide post-earthquake renal disaster relief task force to provide dialysis to patients with kidney failure following crushing injury. And we built this for a while, and at a certain moment I wrote to the World Health Organization telling them what I had done, because I was so proud and it was working so well and we had so much participation and so on. And they said, Dr. Solez, did you realize for the cost of a single dialysis machine, you could provide sanitary water and vaccinations for thousands and save many more people? And, you know, it becomes one of those questions there, and we talk about many such questions in this course. There is no real answer to that. Are we going to say, well, okay, don't treat kidney disease ever? No, that doesn't make sense. And you have all these people in the renal field who are keen to do this. You have dialysis techs who want to fly there and dialyze these patients, and you save lives. But it is unquestionable that the reality that the sort of thing you're doing at a much lower cost affects much larger numbers of people. It doesn't mean that the high-tech medicine where you're spending a lot of money on a few people shouldn't ever be done. But it certainly, I think, anytime you're proposing something where the cost per patient gets in the thousands, one must always consider the sort of thing you're doing where the cost for family is like $10. You know, that's really amazing. What is your thought about this? I mean, is there something morally wrong about international medical humanitarian things where you're spending thousands of dollars per patient on very few patients? Or is it, you know, is there a world where we can accept both things? What are your thoughts?
Well, that's a very challenging question, because, I mean, you know how our intensive care units run here, and they run well into the hundreds of thousands of dollars or millions for a specific patient, and it may not show any survival benefit.
Yes.
It may just prolong life in a very quantitative measure. Mm-hmm. I think the two schools of thought are, well, these kinds of interventions are necessary, and they keep us at the cutting edge of what is possible. And so antibiotics used to be cutting edge. Now they're a human right. In a lot of situations of, you know, the Médecins Sans Frontières, if they go, they need antibiotics, and that's one of the first things they're going to have. That and fluids. Fluids might seem like a very basic thing, but those are basics. And so I think the big question is, unless the basics are met globally, then should we continue to pursue things like ECMO or extracorporeal membranous oxygenation, things like that are very, very advanced and very expensive, when we know that a number of people don't have the basics? And I think that really goes back to the whole idea of this, what are we willing to call ourselves? Are we Canadians helping people, or are we global citizens? Because if we are global citizens, then that does not work. We cannot have us advancing things when people don't have the basics. And what we define as basics can be as little as living at $2 a day.
Right.
And so then I think not continue to move the disparity. So if we knew that somebody in our class was desperately dying and who was in our class, then hence this is our responsibility, we would probably give up a little bit to help them in a more real sense, not just giving. Maybe we'd go out of our way and give up time, which I think is probably a more important currency.
Yes.
But I think the complexity is that we view it's them and us. And I think what I was trying to convey was that the world is getting smaller, and that complex issues like water affect everybody. And so when they're suffering, we may not notice it, but we will. And so I think, in my mind, it seems that we should probably put a little bit of maybe our foot lightly on the brakes of what we're doing with great, very expensive advancements like transplantations and things like that, and maybe consider the public health outcomes on a global scale as a priority for us. Because unless those are met, then really it won't make much of a difference when the global burden of disease outweighs any resources we have to deal with. That if a strain like H1N1 of a flu virus, for example, becomes so potent that it can wipe out a significant portion of the world because we didn't deal with the public health basics, then all of the fancy technologies in the world are not going to matter. So I think it's a little bit short-sighted in how we're approaching technology.
There are so many questions that just don't have absolute answers. As you know, and we've discussed quite a bit in this course, we're heavily involved with starting a new medical school in Nepal that is devoted to rural health. So it's not only a question of what we in the first world should do, but what should that medical school do? Should they be training specialists? I mean, there's such a pride in training specialists and having specialists, in being able to claim that you have in your medical school a specialist in this or that. It's a wonderful feeling inside to have that pride. But I mean, there is an argument, just like there is locally here, that we should have more family docs. We should have more people in general practice. Well, in a very poor country, that argument becomes even stronger. That why are you training all these specialists? Why are you so proud that you're able to do the same things here that we're able to do in the first world? Wouldn't it be better if you put more resources into having generalists? But it just doesn't work for the psychology of the people there to create a medical school they're very proud of and say, no, well, actually, we don't have any specialties. we're all in general practice. That really wouldn't work. But there is a kind of economic argument in favor of that you will always have to face.
I think that you hit it right on the head. It's, I mean, even here, what is the added benefit of having multiple specialists managing very specific parts of a patient? For example, if we have a diabetic and we consult medicine to handle their insulin requirements, and we consult a dietitian to handle this, and they're on a surgical service, what is the added benefit? And all these people are getting paid. And so what does that mean in a public system where we're adding continuously more private or more specialists to the mix that are getting paid big salaries, in a sense, for maybe incremental increases in what we're doing? And I think that's the same thing in the intensive care settings, and is the same things in developing new technologies. If it's a psychological issue, I think that it's really in how we market things, and maybe we should market them a little bit more glamorously.
But just the moment that we think we've come to an answer and it's always one way and not the other, like there are, I forget the names, but there's some antipsychotic meds that were actually, researched first in Canada prior to the US. They were released here, they were very successful. If you hadn't had those specialist psychiatrists working on that, then all those patients who benefited when that new drug came out wouldn't have done so for years later. So
complex.
It's never just, and the nuance, the fact that the expert might know that new fact, which is just going to be change everything, Of course, most of the time, 95% of the time, it's not going to matter all the extra stuff that person knows. But how important is that extra 5%? Well, sometimes it could be the difference between life and death, you know. And if medical science has advanced to a certain level, and you're in a place, wouldn't you like to think that you have people who are at that level to which medical science has advanced, rather than you're down here and the rest of the world? So I don't think there can't be absolute answers to these things.
No, I agree. I think it's so complex and so necessary that anybody who invents things, like I think we started the talk with technologies as they're usually seen as going to usher a new age of advancement, but then we realize that it's more complex and there is harm and benefits to everything. But in advancing things, it's like maybe akin to getting into a really, really fast car and then driving really, really fast, really far away, and then realizing that you left everybody that you were supposed to drop off where you started.
Right. Thank you very much. We're out of time, but thank you very much.
Thank you, Solez.